Well, thank you, Talia, for the introduction, and thank you for Jim as well. So my name is Beth Hayward. I am a nurse practitioner, as Talia had mentioned, in the dermatology department. Today, I'm going to go over basics on skin cancer after transplant, what to know, and how to protect yourself. Like Talia had mentioned, I'm part of the high-risk skin cancer clinic for organ transplants. With that being said, we'll get started. So skin cancer is the most common malignancy after transplant. The general U.S. population lifetime risk of skin cancer is about 1 in 5. But for transplant population, the risk of skin cancer is actually 50% of white transplant patients will develop skin cancer. That's pretty high. So key ingredients to caring for your skin. So know your risk for skin cancer, know how to prevent skin cancer, and know how to detect skin cancers. So know your risk for skin cancer. It does start with kind of your skin type. So, we counsel patients, transplant patients, and non-transplant patients that your skin type does play a pretty significant role. So in this population, you can see if you, Leora, just advance. So the girl with the reddish hair, light complexion, so fair skin has a higher risk for skin cancer in general. We can advance. And then of these people, which would be most likely to have skin cancer? So in this population, it would be the risk for skin cancer increases as we age. So as you see, the woman on the right is of an older age. She has light hair, light skin, light eyes, so she would be at most risk. So skin cancer develops at a much younger age in transplant recipients, so up to 20 to 40 years before the general population. So out of these two patients, who is more likely to get skin cancer? The 63-year-old nun or the 63-year-old farmer? So the history of sun exposure in the farmer increases the risk for him. So you can see a lot of kind of the background sun damage on the farmer here on the right. So transplant patients have additional unique risk factors for skin cancers. So your risk of skin cancer is related to 3 things: the type of organ transplant, the age at transplant, and the type of immunosuppressive medications that you're taking. So the type of transplant affects the risk for skin cancer. So heart is actually at highest risk, then kidney, and then lung, and then finally liver. So age at transplant also plays a role. So the time to the first skin cancer development. So if you were to have your transplant under 30 years of age, you'd have about a 22.3 year risk, and then over 50 years would be average about 11.8 years. So immunosuppression. So this is a big part of development of skin cancers, and we counsel patients pretty highly on this. It's something that you obviously cannot control, and you need these immunosuppressive medications to keep your kidney kind of or your transplant alive and well. But all immunosuppressions indirectly increase skin cancer formation. So it is important to discuss this regimen with your transplant doctors. So your risk of skin cancer is related to, again, type of solid organ transplant, the age at transplant, and the type of immunosuppressive medications. The longer duration that you're on these immunosuppressive medications, the higher the risk, and also the higher the dose, the higher the risk. So decreasing your risk for skin cancer. So this is really important, and we counsel all patients to stay safe in the sun, and we'll kind of go over what that means and some recommendations. So the fundamentals. So UVA, UVB, these, and UVC. The sun emits all of these ultraviolet light. So short-term effects of ultraviolet light: tanning and sunburn. Long-term effects: premature aging, dark spots, wrinkles, and obviously your increased risk for skin cancer. So compliance with sun protection measures is extremely important in organ transplant recipients, especially in patients over 50 years of age and in men. So, real example of a patient that is a what we call frequent flyer in the Mohs department is 65-year-old kidney transplant recipient on Prograf and prednisone. Worked on a ferry, so he was outside, for his career transporting tourists, and he had over 50 skin cancers. So, which is the most effective way to protect your skin from the sun? Avoiding sun exposure, sun protective clothing, or sunscreen? So, it would be avoiding sun exposure. UVB intensity peaks from 10 to 2. So, those are hours that you would ideally want to stay out of the sun. And you can see here, avoiding those peak hours. So if you can do the things that you enjoy to do outdoors during, the 6 a.m. to 10 a.m. or 2 p.m. to 8 p.m., that would be ideal. Sorry, I'm going to hand it over to Leora now.
Hi, everyone. Sorry for the slight pause. We were just unmuting. So Beth mentioned the most important thing to do to protect yourself from the sun is to avoid it if you can, but we understand that that's not always realistic and practical. So there are some other methods for protecting yourself. A good phrase to remember is slip, slap, slop, and wrap. And that stands for slip on a shirt, slap on a hat, slop on sunscreen, and wrap on sunglasses to protect your eyes and the sensitive skin around them. So in the next few slides, we'll just discuss a little bit about sun protective clothing and sunscreen and sprays. So sun protective clothing, there are a number of benefits to using this as opposed to sunscreen. For one, once you put on the clothing, it's there, it'll last all day. You don't have to worry about reapplying it, and it's not oily or messy or greasy. It's often less expensive because once you buy it, you can use it for multiple seasons. And also, as sun protective clothing is gaining popularity, brands are also making the clothes more fashionable, and they're also releasing clothes not just for lounging in the beach, but also for exercising outside and playing sports. So you're probably familiar with the term SPF, but sun protective clothing goes by UPF, which is ultraviolet protection factor. And this is just similar to SPF, but specific for fabrics. So you can see here the best UPF is 40 or 50 or greater, because that's going to block about 98% of the sun. But even clothing with lower UPFs have a pretty good protection. So the reason we started by talking about sun protective clothing rather than sunscreen is because it is more effective. Here you could see a gentleman who did use sunscreen on his face and neck, but you see that he still has some sun damage compared to his chest where he had a shirt on and no sunburn there. Now we'll transition to sunscreen. So we know that choosing a sunscreen can be daunting sometimes because there are so many brands out there and different formulations and a ton of information on the label. So we just wanted to break it down for everyone. So the most important thing when you look at sunscreen is to make sure it has the term broad spectrum, which means it's providing protection against UVA and UVB rays, since Beth mentioned both of those cause skin damage. And then in 2011, the FDA, Food and Drug Administration, released guidance to no longer use confusing terms like waterproof, sweatproof, and instead we use the term water resistant. So you should be looking for sunscreens that are water resistant and check whether they are providing 40 or 80 minutes of protection. So here is a list of some top rated sunscreens by Consumer Reports, which is a nonprofit organization that rates sunscreen, and they found that these were some of the most popular ones. So brands like La Roche-Posay, Equate, Coppertone, and most of these can just be found at any drugstore. So You can take a look. We put some of the average prices there, so you can find one that fits your price range and just get it at your nearby drugstore. The same ratings were done for sun sprays, and you could see Trader Joe's, Equate, also very popular. So these are ones that people have found to like in the past, and we'd recommend you try. We did want to note that the FDA released guidance that you should use caution with sun sprays just because they are investigating the safety of inhaling these sprays. So just keep note of that when you're spraying your face or using it with children. So like we can imagine, sunscreen is only protective if we're using it correctly. So in the real world, it turns out that people really only apply about 25 to 50% of the sunscreen used in testing for SPF. So even if you're using a sunscreen that's SPF 100, if you're not putting enough on, then you're not actually really protected. So some tips. The best sunscreen is the one that you'll use. So SPF 35 might be better than SPF 75 if you're really going to only use 35 every day. You should apply sunscreen 15 to 30 minutes before you go outside to give that sunscreen some time to sink into your skin. Apply it liberally. A good rule of thumb is 1 teaspoon per body part. And make sure to reapply it at least every 2 hours or sooner if you're sweating or swimming. So I think we provided a pretty good argument that sunscreen is important to protect your skin from developing skin cancer, but another benefit is that it's the most effective anti-aging product you could use. So here's a photo of a truck driver with a ton of sun exposure to the face, and you can see what he'd look like with no sun versus sun. The sun damage does lead to, more wrinkled, loose skin, as you can see in this photo. So now we'll go through a few questions. Normally, we'd love to hear from you and keep this more interactive, but because we're doing it virtually, I'll just move through some of the questions. So rigorous sun protection can cause vitamin D insufficiency, fact or myth? This is actually a fact. It was found in one study that in certain groups of people, sun protection can lead to low levels of vitamin D, but this is only in a very strict, controlled laboratory setting. So another study reassured us that the normal usage of sunscreens does not generally result in vitamin D insufficiency. So this should not be a reason that you're scared to use too much sunscreen. If this is a concern for you, however, fortunately, there are many other sources of vitamin D. So you can get vitamin D from your diet by eating fatty fish, milk, eggs, cheese, or you can even take vitamin D supplements if that's recommended by your physician. Next question. If you stay under a beach umbrella, you don't need sunscreen. This is a myth, and this is actually one of my favorite questions because I think many people don't actually really know this. So the reason you do still need to use sunscreen is because surfaces like the pavement, the sand, water, even snow reflects a lot of that UV radiation back up. So at the beach, for example, the sand reflects 17% of UV radiation. So you are exposed to that sunlight even if you're not feeling it. There was a study in a really important dermatology journal that found 80% of people who were under a beach umbrella without sunscreen for up to 4 hours had some degree of sunburn the next day, but only 25% of people who had sunscreen and avoided the sun had a sunburn. So it's a pretty substantial difference, 80% versus 25%. All right, so somewhere along the same lines, if it's cloudy outside, you don't need sunscreen. This is a myth, and I imagine many people in the audience here, including ourselves, had some of the worst sunburns in the cloudy days. This is because clouds only block about 20% of UV radiation, so you can still very much get sunburned on a cloudy day. Also on these cloudy days, we don't have that warming warning. So, when you're out on the beach in the sun and you feel your skin getting hot, that's a reminder that maybe you should get back inside, take a break. But if it's cloudy and often chilly, you don't have that warning and you might stay out for much longer than you really should be. Tinted windows help block UV light. So the answer is it depends. For the most part, tinted windows are meant to block visible light, not UV light. Those two are different. But some windows are made to block some UV light. But in general, your best bet is just to assume that they are not protecting you from the light, and you can go ahead and use like a moisturizer with sunscreen to protect you even on those long road trips inside. All right. Sunscreens that contain insect repellent are as effective as using the two products separately. This is a myth. The American Academy of Dermatology recommends that these products are purchased and used separately, and there are two main reasons why. So the first is that when you add bug spray to the sunscreen formulation, it can actually reduce that SPF up to 30%. So it's not giving you as much protection as you normally would have. And the second reason is that the sun can actually increase the toxicity of bug spray. So you really don't want to be putting as much bug spray as sunscreen on. You want to limit the amount of bug spray that you're putting on your skin. So some tips to follow is to apply sunscreen first and then bug spray. Sunscreen should be applied generously and often, whereas insect repellent should be used sparingly and much less frequently. All right, so just to wrap up a few of the things we mentioned about staying safe in the sun, the most effective way is to avoid the sun. But if you can't do that, then a good start is to just try and avoid peak hours between 10 a.m. and 2 p.m. When you are out in the sun, the best thing to do is to wear sun protective clothing for long-lasting protection. But sunscreen is also really important. So when buying a sunscreen, try to get one that's broad spectrum, over SPF 30, and water resistant. And again, the best sunscreen is the one you'll use. So now that we've talked about how to protect yourself from the sun, we're going to move on to detecting skin cancers so that you can detect any lesions if they've already developed. The reason we want to talk about this is because early diagnosis can truly save lives. Almost all skin cancers start at an early curable stage. So it's really important to catch them early before they cause further damage. So we'll go over the three main categories of skin cancer and how you can find them on your own body. So we'll start with squamous cell carcinoma. This is the type of skin cancer that is the most common in transplant recipients. So this is what we see most commonly. And it's because it's 65 times more common in transplant recipients than the general population. So this type of skin cancer often starts with a precancer bump. So as you can see on the bottom left, they sometimes first develop from a pink, red, or brown spot with a rough surface. And sometimes you can actually feel these more so than you can see them. And if they're not treated or removed, they can then develop into a full-blown squamous cell carcinoma, as you can see on the right. So these usually look pink and scaly, and they're often in sun-exposed areas, so your face or your hands, but they can be elsewhere as well. And these are really important to detect because they act a bit more aggressively in transplant recipients as well. Another type of skin cancer that we see often is called basal cell carcinoma. And you can see by the picture here that it looks a little bit different than the previous photo. This skin cancer is 10 times more likely in transplant recipients. And it usually looks like a shiny pink bump or patch. And it's often in similar areas, like where the sun hits your face, your hands, but again, it could be anywhere. And sometimes you can actually notice these if you have like a wound that is bleeding or crusting repeatedly and just isn't healing, that can actually be a skin cancer in disguise. All right. So now melanoma. This is the most dangerous and deadly skin cancer for all people, not just transplant recipients. But fortunately, it's not as common in the general population or transplant recipients. So it's only 4 times more common in this group. And the way you can see these is by looking for any irregular brown spots, as you can see in the figure here, or a changing mole. So this is a mole that's growing in size or changing color. Or sometimes we use the term ugly duckling, which means a mole that just like looks really different from everything, from all the other moles on your body. It's good to keep track of those. So we recommend doing self-exams. You are your best first line of defense. You know your skin probably better than anyone else. And it's important to get familiar so that you can find these skin cancers early on if they develop. So all you need for a self skin exam is a mirror in front of you and a hand mirror. And we recommend doing this every month. So there's really no standard way to do it. The best way is the way you'll remember. It doesn't matter if you're going from top to bottom, from side to side. What matters is that you're just checking your whole body and you're not missing any areas. So as we mentioned, the skin that is exposed to the sun is often where we find skin cancers, but they can develop anywhere. So it's really important to check other sometimes neglected areas, such as the underarms, the palms and soles, fingers and toenails, and also the back, buttocks, and genital area. So in addition to doing self-checks every month, it's also really important to get a skin cancer screening by a dermatologist. And they should be doing a full body examination and looking at all the same areas that you look at, so they get a full picture of what your skin looks like. And we recommend that this should be done at least once a year to make sure that nothing is changing. But some people might even benefit from more regular surveillance depending on, their medical situation. So our take-home message, this presentation isn't to instill fear in anyone. It's really actually to empower you all and to have everyone realize that you really do have the ability to decrease your risk for skin cancer by protecting yourself from the sun. And you also have the ability to detect skin cancers before they're dangerous with self-skin exams and regular checkups with a dermatologist. So here we have the information for our high-risk skin cancer clinic, and I think we're going to open it up for questions now. Hi, Talia. I think you're muted.
Hi, sorry about that. So I have all the questions. There's quite a few. And I'm going to unmute, Elizabeth's unmuted, and I'll try to unmute the rest of your team as well. But the first question came in by email before the group started. So someone had asked, what are thick, dry skin spots that are scab-like, which occur on the scalp? Should they be treated, and how?
So as far as some of this
go ahead, Beth.
On the scalp, so they could be a variety of different things. They could be just benign lesions or a benign kind of scaly condition that can happen on the scalp sometimes. But they could also be precancers or early squamous cells or full-blown squamous cell. So that should be evaluated by a dermatologist. And if they don't have one already, we can help to get that patient in. The transplant teams within Penn are really great about referring these patients if they haven't seen a dermatologist, but really they should be evaluated for these spots.
Okay, great. Thank you. And the other question that came in by email, which I brought up a little earlier to you guys before it started, was, do you know of any sunscreens that don't leave an orange stain on white clothing? And this person has well water, and potentially maybe that could be the cause.
Yeah, we were briefly discussing this earlier. We weren't exactly sure if it's a relationship with the well water. I would say a good place to start is those sunscreens and sunsprays that we listed. But if none of those are working for you, then protective clothing could be a really good option. They will definitely not leave any stain.
Okay, great, thanks. And actually, someone had a follow-up question to the first question, was, as far as those scabs or spots they might see, would there be pain associated with them, or could they potentially be warm to the touch?
So pain sometimes can come with skin cancers. There are different symptoms that people have. Sometimes patients don't have symptoms at all. So, but pain is definitely a symptom that we hear pretty frequently: bleeding, itching, things like that. So, again, I think it's something worth being evaluated. Again, like skin cancers or precancers, they don't go away. So regardless if it's benign or not, it should be evaluated.
Great. And someone asked, and maybe you could do this while we're asking, or we're going through the question. Could you go back to the presentation that showed the sun protection, the sunscreen recommendation, so people can see that again? And this will still be available on all of our websites afterwards, but for those of you who might be taking notes now, they'll put that back up. So another question that was put into the chat box was, are you aware of the risk in lung transplant patients?
I can take this question.
Maybe Dr. Shin.
This is Thuzar Shin. So I did see that question. I think it's a really great question. So when we talk about risk factors, it's really important for us to not take each risk factor in isolation. So, lung transplant. So the reason why sometimes the numbers that you see on some of our slides don't always have every single type of transplant. It's because there's so many different studies that are done on different transplant populations. And for whatever reason, sometimes they only do it on kidney patients because there's so many kidney recipients. Sometimes they only do it on heart transplant recipients. So it's sort of an aggregate data pool. And it includes patients from many different age groups. So it's as young as 18 all the way, to their 70s, all different types of transplants. And then a lot of patients with, different skin types and prior history. So it's sort of a hodgepodge group that we study. So specifically for lung transplant patients, we do consider that as a higher risk group, similar to if you saw that one slide that Beth showed, that it's really heart and lung. We usually group them together as a thoracic organ. So many times in studies they're grouped together as a thoracic organ, mainly because those two organs are pretty intensely suppressed with medications. Most of the time, those patients are on, double at least, if not triple immunosuppressive therapies. And kidney also, we also know that is also intensely immunosuppressed. I would say in contrast to liver, which sometimes a lot of liver transplant patients are managed just on tacrolimus alone. So I would say lung, I would group in with the heart transplant recipients in terms of the risk. But I would say just because you have a lung transplant doesn't mean you're guaranteed to get a skin cancer. I would, when you come in for our assessment, we always kind of take a whole picture into consideration. So I would say the most important or the biggest risk factor for developing a post-transplant skin cancer is having a skin cancer prior to your transplant. So that's for all organ types. We also take into account, obviously, your gender and your age, and then really how much skin or sun damage that you've accumulated over the years as well. So in terms of lung, I would group that up as a higher risk organ in terms of risk for post-transplant skin cancer, similar to the levels of heart.
Great. Thank you, Dr. Shin. And do you want to take the next question that was on the chat box, which was, what are the risks of for people of color?
Yes.
Do you know that?
Yes. I'd love to answer that. And that's a really, really good question that we don't have a lot of data for. So, like I was similar to the lung transplant patients who are pooled with all different organ types. When we look at registries and even institutional-based databases, it includes patients of all skin types and colors and ethnicities. And we do know that most of our transplant patients that come in with skin cancers are Caucasian. So they tend to be white males who've had a lot of sun. So, there's been more recently, one of our colleagues over at Drexel, she actually did a study on just skin of color patients that follow at Drexel. And she did find, I would say, a significant portion of skin of color patients that develop squamous cell cancers. But what was interesting in her study is that she did find an increased incidence of genital squamous cell cancers in skin of color. So the mechanism of developing those skin cancers might not necessarily be related to sun exposure or how your skin reacts to the sun, but it might be related to other things like human papillomavirus or HPV, the virus that causes warts. So that's probably the only really good study that only included a few hundred patients that we know of that looked at just skin of color. So that's why it really is important to really look from head to toe. And we, in the absence of any really evidence-based guidelines, we recommend screening everybody at least once a year, and sometimes that can be less frequent depending on kind of how how your skin assessment goes. If you really have zero risk factors, no lesions of concern, and you've never gotten a sunburn, you have no sun damage, and we might have you come back in 2 years. But we would still recommend screening everybody, even including patients with skin of color. We have seen some aggressive squamous cell cancers and some basal cell cancers and even melanomas in patients with skin of color. Patients who are darker complected tend to have moles really on their hands and feet, so we counsel them a little bit differently in terms of the skin exam. And I would say one of the most important things about what we ask you when you come in for your visit is how your skin reacts to the sun. So not many people know this, but every skin color has the ability to burn. So from the lightest complexion to the darkest complexions, every shade in between has the ability to burn from the sun. And so that's a really important question for us to assess how your skin really kind of reacts to the sun, because there are some conditions and some medications that do increase your risk for sunburn and sensitivity to the sun, regardless of what color your skin is.
Great,
also,
thank you so much, Dr.
To touch on that just a little bit, I was also looking at a recent article about this, and it might actually have been the same one. And whereas the risk in white transplant recipients nears like 50%, in non-white transplant recipients, it's one study said it's less than 10%. But this group also has reported having less skin cancer education and screening. So even if the risk is lower, it's still really important to increase awareness and not to think that the color, that darker colored skin is less at risk, because everyone needs to be, checking the health of their skin and making sure they're finding any skin cancers at an early stage.
Great, thank you, Leora. So should a transplant patient be seeing a dermatologist who specializes in transplant, or can they see any dermatologist?
I can answer that. So I would say it depends. So the expert consensus guidelines do recommend that a skin cancer screening be performed by a dermatologist. And I would say, whether or not you need to come to our high-risk clinic depends on not just your risk factors, but sort of your history of skin cancer. So I would say all of our medical dermatologists at Penn can do routine skin cancer screenings. And if you're only needing maybe 1 or 2 biopsies at a time, and you're not developing that many skin cancers, it's safe to follow with a medical dermatologist. The patients that really need specialized care are really the patients at highest risk for developing multiple or numerous skin cancers. So that's both developing multiple skin cancers at one given visit, say they're called synchronous skin cancers, where you have multiple skin cancers developing at the same time. And then also patients who develop numerous squamous cells or basal cell cancers over time, meaning, we have one liver patient who I've seen him for the past maybe 4 years. He's developed over 100 over that period of time. So once you kind of pass a certain threshold, it would be helpful to follow with physicians that can both treat your skin cancer surgically, but also kind of talk about some strategies, such things that are called chemoprevention. There are medications that we reserve for patients that have the highest risk or the highest burden of skin cancers, namely squamous cell cancers. And it also helps if you have what we call a high-risk skin cancer. So high-risk skin cancer, meaning they're usually skin cancers that develop very rapidly, that are very that quickly grow to a large size, and that can grow deeply in the skin. And those have a higher tendency to spread to other parts of the body. And we tend to have to utilize what we call multidisciplinary care, and work with our colleagues in other surgical specialties and possibly radiation oncology or medical oncology to get those under control.
Okay, thank you. And the next two sets of questions, I'm going to group them together. So the one was, is around the protection. So one person asked if what the effectiveness of ceramic window tinting is on their car. And then also for the sun protective clothing, does it lose any effectiveness after it's washed, like repeatedly washed?
Beth or Leo, are you still there?
I am not sure about ceramic window tinting. I would have to look that up, and I'm sure there's some type of manufacturing information online. But even if there is, I don't think that the protection would be as strong as some of these other options. So I don't imagine that it's like blocking 98% of rays. So I think that you would still benefit from wearing sun protective clothing or sunscreen. And then in terms of the clothes, multiple wears, I have not seen any information that it loses its protection. But I have heard of like certain brands recommending certain types of detergents. So I think that before you go ahead and purchase any clothing, you should dig a little deeper into their website, or if you're buying it in person, with a store representative and ask. But in general, I think that you could get, a few seasons out of those clothes.
Yeah, I would recommend reading the label. Some of the manufacturers. So the UPF is related not just to the material itself, but also how dense the weave is. And there are some detergents that you can wash your clothes in to get some SPF or UPF into it. So it might be slightly different from garment to garment. So just making sure that you read the label and then definitely following the instructions, because putting in the dryer might compromise the integrity of the garment. And then in terms of the window tinting, I would ask whoever put the tint on for you, you might want to ask the breakdown between UVA and UVB blockage, because it might be different, just like Leora alluded to, that the UVA and UVB rays, they are different wavelengths, and not all of the window tints block both in sort of the same fashion. So you might want to specify or ask, because they may say it's 100% UV protective, but they may be only referring to UVB. It's only in the recent, couple decades that we've really also turned our focus to UVA in terms of its ability to cause DNA damage and skin cancer.
Okay, thank you. And then I'm going to end with these last two questions. So the one question is, do you know of any studies or data that show specifically what immunosuppressant drugs the skin cancer risk is higher? And then also this was put in the chat box. I don't know how to pronounce it, but nicotinamide. And how effective that is in reducing skin cancer.
Okay, so I can start with the immunosuppressive medication. So, I would say the challenge when studying all these medications is, there are studies that show their effects in cells, so outside of the body in cultured cells. And then they're also done, I would say, in cohort studies. So they're not really ideally set up for really telling you which one has the worst skin cancer outcome. Because most of the time, this is done retrospectively. They'll look at, okay, well, what is the skin cancer incidence in patients that are on this regimen or that regimen? And honestly, sometimes your regimens change over time due to different things. Like, so you might have to add a medication because you're going into acute or chronic rejection. You might have to come off of a medication because you're not tolerating it or it's affecting your kidney function. So there's so many things that sort of affect these population-based studies. But in general, we do know that the worst offenders are called calcineurin inhibitors. And so that's a class of medications that include cyclosporin, which is really kind of the drug that really revolutionized the transplant surgery, revolutionized transplant surgery. It allowed us to do these transplants and have these grafts survive in patients. So that was really the turning point in terms of transplant medicine. But cyclosporin and tacrolimus is also in that family as well. So really, cyclosporin is really the classic drug, the classic calcineurin inhibitor that is most associated with skin cancer. Tacrolimus is also up there as well. There's an older medication that some patients are still on called azathioprine, which is a nucleoside analog. So that we do know also sensitizes you to both UVA rays and also increases your risk for skin cancer. Cellcept and prednisone don't have as much of the skin cancer risk. But obviously we as dermatologists don't advocate for taking you off any of these medications without consulting your transplant team. There are new medications called mTOR inhibitors. And so these are called mammalian targets of rapamycin. That's what mTOR stands for. The first one that was studied was sirolimus, and there are new versions of it. One's called everolimus. And so the study on or the data on those medications are promising in that there is evidence to show that it slows or it sort of prevents what we call neoplastic growth. So it can be preventive or protective against skin cancers and other cancers as well. I would say there's conflicting data depending on which population was studied and when the exposure to the medication was done or was given to the patient. So and it's gone both ways. So there's some studies that show that it's protective, and then there's also some studies that have shown that any exposure to mTOR inhibitors is associated with cell carcinoma. But it's unclear whether it's really due to the medication or due to other factors, like perhaps a lot of times patients are switched over to an mTOR inhibitor once they've developed a catastrophic number of skin cancers on their traditional regimen. So I would say, more data or more studies really need to be done to kind of flesh out that relationship. But in general, the mTOR inhibitors are considered to be less associated with skin cancer risk. They have other risks, like effects on your kidney, and also it can affect wound healing from very big surgeries and things like that. So again, it's not something that we as dermatologists make the decision on, but definitely your transplant teams would be able to answer questions about your immunosuppression regimen. And then moving on to the nicotinamide question, that's a very interesting question. It's a good question. The the data on nicotinamide that was published in the New England Journal of Medicine was done in a cohort of patients that were all immunocompetent. So none of them had an organ transplant and nobody was immunosuppressed. And they had very few skin cancers over a period of 5 years. And statistically, if you talk to a statistician, they would say that the results are really they're unimpressive, but there was a reduction in squamous cell cancers and actinic keratoses, which are precancers. So everybody, at the time of publication, was very excited about this because nicotinamide is a B vitamin with minimal side effects compared to some of the other options that we have to prevent skin cancers. But unfortunately, there really hasn't been a good randomized controlled trial in transplant patients. There's one that was done with very, very few patients that were kidney transplant recipients. There were maybe 20 patients in the study. So it was very underpowered, meaning they didn't have enough patients in the study to really to be able to discern any effects on skin cancer risk. But they did show that it didn't affect any blood pressure, or it did not affect the creatinine, which is a measure of kidney function. So they did deem that it was safe to use in kidney transplant recipients. So what we've done at Penn in general is, we don't know whether it helps or not. But that's really kind of all we have to give you at this point in terms of chemo prevention that is of minimal risk. So we do suggest, if you are interested in taking the nicotinamide, that we definitely need to be in touch with your transplant team to make sure it's safe for you to be on it. And so we also work with our transplant pharmacologists so that they can look at some of the drug interactions. And then we also make sure that you buy the right medication, the right supplement, because niacin, although it sounds similar to niacinamide, niacin works in a completely different manner and actually causes flushing. So we don't recommend niacin. So we just want to make sure that you get the right right supplement if you're interested in it. So we usually tell patients we can't promise it's going to help, but as far as we know, it doesn't hurt.
Great. Thank you so much. So that is it for the presentation today. Thank you to Penn Medicine's high-risk skin cancer team for putting this all together. This is amazing.